So while everybody's getting settled, why don't we start the next session here at TCTAP. It's my pleasure to open up the session on a live case presentation from Severance Hospital. I'm one of the moderators, Lawrence Garcia, out of New York City. My co-moderator is one of my best friends out of Japan, Hiroyoshi Yokoi. Also on Panelist, we have Dr. Dudzinski, Dr. Su, Dr. Lee, Dr. Michael Lee, Dr. Sang-Soo Lee, Dr. Hyung Park, and Dr. Chang-Hwan. So I'm not sure if we are ready at Severance Hospital with Dr. Ko. Do you have the, I want to see if they're ready. I can hear the... Hello.
Good morning.
Hey, Dr. Ko, Dr. Garcia, how are you?
How are you? Good morning.
Good
Welcome
morning.
to Severance Hospital. So it's great to see Dr. Garcia and Dr. Yokoi again, and all of the panelists, and welcome to our hospital. So I'm glad to share our case today, live case. So let me introduce our team. On my right side, we have my junior colleagues, Dr. Cheol Lee, and on his right side, Dr. Sun-Ho Kim. And we have a good supporting team of nurses and technicians, and also we have support from the anesthetist for sedating the patient. So, Dr. Kim, could you introduce our case?
Okay. Good morning, ladies and gentlemen. I'm glad to introduce our case. This case is 78 years old male patient, and he came to our hospital for both legs claudication 1 month ago. He had medical history of peripheral disease, and he already got PTA and left SFA last month, and he had coronary artery disease and dyslipidemia and chronic kidney disease. Recent laboratory findings showed mild anemia and mild elevated creatinine. He was prescribed for aspirin, clopidogrel, cilostazol, and rosuvastatin. At the first time visit in PBR, PBR showed both legs low ABI. Next, please. And in the peripheral angiography, the PNGO revealed left SFA ostium total occlusion. So we tried retrograde access via distal SFA distal puncture. Then, next please. We succeeded wiring to the distal region, and we performed DCB on left SFA. And next please. And this is the final angiography. Next please. And follow-up PBR showed improved ABI in left side. And next, please. And here is the right peripheral angiography. We didn't perform CT angiography because he had CKD. And in the peripheral angiography showed also total occlusion from proximal side in right SFA. Next, please. And here is the consideration on procedure.
So far, the history of the patient. So this patient had decreased EGFR. So usually in Korea, we took a CT scan prior to procedure. Ultrasound is not commonly used, only in patients with CKD, but in this patient, no ultrasound was performed. But we have the angiogram from last time, and it showed the total occlusion of proximal, the mid portion of the SFA, and diffuse stenosis of proximal and distal SFA. So let me show you the baseline angiography. Oh, sorry. Yeah. This is the baseline angiography. Run again. Yeah. This is actually low dose contrast angio. We dilute the contrast up to 10% of the usual dose. And with the software setting, we can visualize the arteries very well. So as you can see, 1/3 of SFA is visible. It shows diffuse stenosis. And middle 1/3 is totally occluded. And again, the distal SFA and the popliteal artery is patent, but shows a diffuse disease. This is the next angio. Okay. Yeah, this is the distal part of the SFA and popliteal artery. So P1, P2, and P3 segment is intact and shows no significant stenosis, but P1 segment shows diffuse lesion. So this is the situation here. So what would you recommend in this patient? So our strategy, let me introduce our strategy. Back to the slide. Slide 보여주실까요? So I think even though we can have good chance to pass the Y from the antegrade, but if that fails, then I think in this case we can use the retrograde approach additionally. And so I prefer to have a bidirectional approach in patients with total occlusion. And then we will check whether the wire was intraluminally passed or whether wire is located subintimal. So for that purpose, YVS is very useful, and also we can measure the dimensions of the vessel. And based on that IVUS measurement, we can select device. And even though this patient shows no heavy calcification, I think this patient shows long lesion. So in the long lesions, I think the beta stenting rate is relatively high. So in order to avoid beta stenting, if the wire is luminally passed, then I would do arthrotomy prior to using the dilute devices. For my preference, for this patient, I would use DCB instead of DES. However, if the wire is located in the DES, in the subintimal space, and then I may consider DES too. So these are my thoughts. What do you think about this case?
Professor Ko, I'm Kevin Chung-Ho from Taiwan, and it's good we have a good weekend several days ago in Taiwan. So
Yeah, good to see you again.
yeah, good to see you. And my several questions. First, do you use CO2 angio in Korea if the renal function is impaired? I see you just use the dilute contrast. Second is I saw the anesthetic machine behind you. So is there a routine to use such a general anesthesia for the patient, or just because the demo to stabilize the patient? And
yeah, the patient is under light sedation, so the patient does not under general anesthesia. So just to pain control, we gave some medicine, and which also sedate the patient a little bit. So this is good for the procedure for me and also for the patient. The patient senses less pain during the procedure. And we also use CO2 angio, but the image is not very good, and also patient sometimes feels pain. So if the renal function is not severely decreased, then I prefer to use low dose contrast angio.
Yeah, Dr. Ko, I think this is a great case, and I think I think you're going to cross this antegrade. I think there's a long enough stretch of artery that you probably get through it. If you were to go bidirectional, are you going to go pedal, or are you going to stick in the frog-legged position higher up in the distal P2 segment for your retrograde access?
Yeah. Previously I preferred to have the pedal access at the level of distal tibial arteries. But these days, recently, I changed my strategy. It is easier to puncture the proximal ATA. As you can see on the angiogram, if you spread the space between tibia and fibula as wide as you can, then in that projection, you can clearly see the anterior tibial artery. And the anterior tibial artery is originated from the popliteal artery from the behind the knee joint, and then it comes through the membrane, interosseous membrane, and it comes anteriorwards. So you can puncture easily the anterior tibial artery, and then also you can achieve easily the hemostasis after procedure, just by the compressing. So let me proceed. The next angio. Since the transmission time is a little bit short, so we did some work. So we punctured the anterior tibial artery. Next. Yeah, so this way I could bring the wire from the proximal ATA to the SFA retrogradely. And then I changed the wire from the Gladius 018 to Halbert 014 wire, because the previous wire, the Gladius, could not go through the occluded segment smoothly. So there was a small branch, and I think with the Halbert wire, I can better navigate the wire into the direction where I want it. And as you can see, just by drilling, it was not that difficult to bring up the wire to the proximal SFA like this. Just rotating the wire, and then if the wire does not go straight, then I can pull back the wire, and then again I try to go upward and in straight line. And as you can see, I was almost there, and I checked the position of wire in different projection, and it touched the proximal wire, and then I brought a multi-purpose wire from the above and tried to snare out the distal wire like this. And then I could externalize the distal wire. And then from the above, I advanced the microcaster along the wire. And then I switched the wire direction. And then here I checked the total popliteal artery and SFA with the IVUS. So can you see the IVUS image?
Yes. No, we're still seeing angio. Now IVUS is up.
Yeah, this is the baseline IVUS image. Yeah, I did manual pullback. The distal vessel diameter is about 5 millimeter. And there was some negative remodeling in the middle portion. There is some calcium, superficial calcium, but not heavily calcified. There are some spots. Yeah. And as you can see, the wire is located interluminal. The proximal vessel diameter is also about 5 millimeter. Yeah. So this is the baseline IVUS image. Do you have any comments on that?
Dr. Ko, I'm Yokoi, and thank you very much.
Yeah.
Very nice technique that guide wire and good crossing, getting the interluminal. Ask to you the next step, the not so much calcification exists, I think. So atherectomy, do or not? That's the firstly discussion point, I think.
Yes.
How do you think?
Yeah. So one of the algorithm, there is many algorithm to treat for the treatment of SFA and femoral peripheral artery. It says we can predilate the whole lesion with small balloon and then see how what the lesion looks like, whether lesion shows dissection after balloon angioplasty, and if we observe the occurrence of the severe dissections, then the preferred strategy is DES, and if the dissection is not severe, then we can treat the lesion with DCB. But actually, personally, I don't like to perform the long stenting in SFA.
Yeah.
So maybe for 1 or 2 years, maybe the drug is still released and the stents can remain the patent. But after 1 year, so after all drugs are released, then we have the bare metal stent. So, and with the current bare metal stent design, I think as the lesion, the stent length gets longer, the patency rate is not so good. So I prefer to treat the patient with nothing left behind strategy. So that's why I prefer to do atherectomy if the wire is located in the internal space and if the lesion is long or heavily calcified and so on and so forth.
Kevin, and I think in the past for this kind of non-calcified long occlusion, our favorite is to the laser atherectomy with DCB. Yeah. And nowadays we prefer to use Rotarix with DCB because of the speed, because Rotarix is faster. So I don't know, I also does not like to put stents, and if there's so much material inside the vessel, I still will try to remove it, then use DCB.
I would consider directional atherectomy. I wasn't very impressed with the level of calcium, so I'd want to debulk if you're going to proceed with the primary strategy of DCB.
I think the data from reality would say that that's probably a good choice, but that was heavily calcified. At the end of the day, I think what we're dancing around is one of my pet peeves is that when we do these long CTOs and we do these cases where we want to just do DCB and leave nothing behind, we don't know the failure mode. So, if you ended up with an occluded artery to start and the outcome at 6 to 12 months is another occluded artery, then that choice is probably not useful. But if you had an occluded artery and it fails in a multifocal or a focal way, then that's a great idea. So it's a cost analysis as well. And unfortunately, we still don't know that answer, which is really a challenge in my book. But before we can go back and forth on the panel, do you want to continue there, Dr. Ko? What's going to be your plan? What atherectomy device do you want to use? And are you just a heparin person at this point now that you've externalized and integrated your wire? What's your next steps?
Yeah, actually after seeing this, as I said, I decided to perform atherectomy, and you can use either any kind of atherectomy in this case, since the calcification is not severe, and the plaque burden is very high, so very large. So, but I think for me, in such a long lesion, then I prefer to use a jet stream. It's easier to use, so I placed distal for the protection of distal embolization. I placed embo shield, and next angio.
플로로 영상으로.
Okay.
No.
Okay.
IVUS to
IVUS angio. Okay, and then we performed atherectomy. This is jet stream. And the key point in the use of the jet stream is to do the procedure very slowly. So advance the jet stream catheter very slowly. And I divided the whole lesion in 4 segments, and I did 2 passages without blaze up and 2 passages with blaze up. And after the atherectomy, we took the angio. This is the, in the meantime, as I advanced the chest stream catheter, our patient complained of pain. So, and somehow the chest stream catheter was stuck in the middle of the SFA. So I decided to pre-dilate the lesion with a 2.5 millimeter balloon first, and then I had no problem to advance the chest stream catheter. And I finished the atherectomy. After that, we took angio. Next. Yeah, this is the angio just after atherectomy without pre-ballooning. And now we can check the vessel with the IVUS.
And Dr.
Can you
Ko,
have IVUS? Yes.
and Dr. Ko, as you taught me, do you want to talk about your jet stream process? You do blades down, blades up, but then you also RX between cuts, correct?
Yes, right.
That's one of the great teaching points.
Yeah. So can you see the IVUS image now?
Yes, sir.
now.
Yeah, this is just after atherectomy. So I will pull back. This is popliteal segment, P2 segment. This is P1 segment. And distal SFA. 패닝 좀 해주세요.
Here.
Yeah.
Professor Ko, do you have chromal mode pattern? Because just there, maybe there is a subintima hematoma. If you have chromal flow pattern, it will be even more easier to see. And it's also a common complication or
go back to
situation
the-
after gesture.
Yeah. Maybe subintima. Okay. Let's check.
I think it shows two things. One is you're always going to get dissections,
here.
right? And you're also going to have some
Yeah, here.
hematoma formation. But critically, atherectomy, without really being super aggressive, the Japanese taught this to us back in the day of directional atherectomy in the coronaries. The plaque volume is immense in these arteries, and so you're never going to get to the Glagoff remodeled stage of an artery, which is what Abacus tried to get to. But this just shows you the plaque volume is still, 60, 70%. It's really trying to make a lumen that's normal for the vessel at this point.
So after seeing this, do you have any recommendation?
Dr. Su, do you have any recommendation for the hematomas?
So it's the size of the jet stream is 2.4 over 3.4,
2.4, yeah.
the largest already. Yeah.
So I think since there is no compromise of flow and the lumen is still wide, and I think we can just proceed. So would you recommend pre-dilation before application of DCBs, or do you think we can go directly to DCB application?
Do you guys want to have a show of hands, or you guys want to vote? How many vote for pre-dilatation on this vessel? How many just say straight away with DCB? It looks like the
Okay, so
consensus
we'll
on our
follow
end
your
is pre-dilate there, Dr. Ko.
NC balloon 주세요. 550.
So,
So
while
we'll use
I was just going to say,
NC balloon.
to that point, the Italians, Marco's paper, really showed that, at least in the global impact data, with the long lesions, it was a 40% to 50% stent rate.
Yeah.
So that was, again, because of lack of predilatation. In their trial, again, 17 or 19 centimeters, I can't remember. Remember, the pivotal trial was 10, but they did predilatation for 4 or 5 minutes, and then they did their DCBs, and their stent rate fell. The pivotal trial was around 4% or 3%. This one was 6%. So I think it does give some validity to going down a DCB route.
And so how many will use, Professor Cook, will you consider maybe a chocolate balloon to even decrease the dissection rate? and then
Yeah,
long
but
balloon
chocolate balloon is
inflation.
not available in Korea, so we have to rely on NC balloon in this case. So since the calcification is not that severe, I think the usual conventional NC balloon will do. So, and let me check.
Professor Ko,
It came up a little bit higher, so I bring it
Yeah.
up. Okay, so I think.
So Dr. Ko, while you do your pre-dilatation, you're just using a simple balloon. We can have a discussion offline about the specialty balloons here. We do have a featured lecture. Do you want to let us get to that while you do your pre-dilatation? And then we can come back to you following the pre-dilatation for your final results?
Yeah, I usually use just the NC balloon after atherectomy. If the calcified lesion is very short, then instead of using atherectomy, I can use, I prefer to use the scoring balloon or cutting balloon. But in this case, we did already atherectomy, and I think just conventional non-compliant balloon will be enough. But if we have the available specialty balloon, like a chocolate balloon, so if there is reimbursed, then I think we can use that too. Okay, deflation. So even though you recommended 5-minute inflation, but because of the limited time, so I have to do it a little bit quicker.
Yeah, no, that's an eternity in these live cases. Why don't you continue with your pre-dilatation, and we're going to move on to our lecture, which is from Dr. Yoon, and then we'll be checking in with you in about 8 minutes. Dr. Yoon is going to be discussing infrapopliteal endovascular intervention, strategic selection, and outcomes of interventional revascularization. Dr. Yoon.
Thank you, Chairman. Good morning, everyone. Thank you for the opportunity to present today. My name is Chang-Hwan Yoon, and I'm from Seoul National University Hospital. I have nothing to disclose regarding this presentation. My presentation can be summarized with this flow chart very shortly. I think we don't have much time, so I skip many slides, my slides. Anyway, strategic selection based on whether there is a presence of occlusion or not, and then if the lesion length, and then calcium presence, and then the success of anterior wiring or not, and then if there is an option, maybe we can have some other options. We can perform the simple balloon like this, and then if the short occlusion, we can navigate anterogradally easily, but if the lesion is long, like these cases, with heavy calcification, we have many variety of techniques we can use. And then, of course, the collateral channel use and the pedal loop is very important for infrapopliteal intervention, like this case. And then sometimes there is very hard to use pedal loop, and then we can select another alternative channel like this from peroneal artery to lateral plantar artery, and then we can open the anterior tibial artery like this. And then sometimes we use the collateral from peroneal artery to posterior tibial artery to open the posterior tibial artery. And then if there is a heavy calcification like this case, it is very hard to navigate anterograde only. And so we definitely use the pedal puncture and then navigate the wire like this, and then for the passage of the devices, of course. And then this is ATA puncture like Dr. Ko's today's presentation, and I use the ATA puncture frequently, and then we can navigate like this and then open the artery, palmatial to tibial artery like this. And then, sometimes we perform the below the knee vessel very well, but there is a case where there is no wound healing occur. So on the detailed observation, we can find a very severe stenosis in the plantar artery. When you open this artery, the wound healed. So outcomes of interventional revascularization, we need outcome evaluation very well. So we perform ABI and duplex ultrasono in addition to symptom and sign follow-up. And we compare the endovascular outcome with surgical treatment. Budget trial showed comparable until 2 years. And the recent best CRI showed a better outcome in saphenous vein graft group, like this. And the budget 2 trial showed the opposite. The best endovascular treatment group is better. But the difference is mainly driven by the difference to baseline patient and lesion characteristics, I think. And then to have better outcome of endovascular procedure, we need angiogen concept or direct flow and structured approach. And when there is no option, we can use transcatheter arterialization of deep veins. To improve the outcome, we need more. And then for one example, we can use the drug technology. And then many DS study shows the promising outcome, but we need more data. And then this is only limited for short lesion. And then recently, the resolvable vascular scaffold showed also promising result. And then another drug-coated balloon, sirolimus-coated balloon are under study. And then this study shows a promising outcome. And then more larger and randomized controlled trials are ongoing. And then we are looking forward to seeing the results soon. And of course, it is very important to prevent the complication during infrapopliteal procedure. Most of them are perforation, and then we need to occlude them very well, and then manage the patient first. And let me conclude my presentation. The procedure success rate is very high now, and then operators are very equipped and then very talented. So we improve the success rate very much. But personalized approach that takes many variables into consideration is likely the ideal strategy in obtaining the most rapid wound healing and thus the best clinical outcome. Thank you for your attention.
Thank you. That was a great presentation. It actually got us back on time. So, Dr. Ko, we're going to be back with you if you're available.
Okay, so we performed the pre-dilation with 5 millimeter balloon over the whole length. Next. Next. Okay, this is the angio after pre-dilation. Okay, okay, this is the distal part, back. This is the proximal part. So I think there is some dissection at the proximal segment of SFA, but maybe there is small, maybe some injury of the wall at the mid segment of SFA, but I think no free perforation. So far I think it looks not so bad. So next, we used impact DCB, 5 millimeter by 200, and deflation. So for the proximal part, we will use also 5 millimeter impact DCB.
And Professor Ko, is that you don't have a long balloon for usual balloon, maybe 20 or 30 minutes? 20 or 30 centimeters.
20 minutes? A bit long. So 3 minutes. I usually apply 3 minutes for DCB. So do you apply longer time for inflation?
You know, in the pivotal trials, at least in the U.S., it was 3 minutes for the total duration of drug dwell, and it worked. I think Makari went to 4 minutes for drug dwell. At the end of the day, for those of us old enough to remember the old angioplasty days, what's old again is new again. So the longer you do angioplasty, the better. It just gives you a better luminal result. But whether or not it transfers more drug on a device which loses 90% of its drug just in transit is probably not germane to this. But the angioplasty, of course, is still the mechanical side of it.
Yeah. For coronary artery, just 1 minute is usually sufficient. So I think longer than 1 minute, I think that'll be okay. That's my opinion.
Dr. Ko, I'm Yokoi. I have one question.
Yes.
I asked to your thought that the low dose paclitaxel coating balloon versus high dose, similar or
Yes.
different? How do you think that?
We had the first impression that low dose paclitaxel DCB is a bit inferior to high dose, but we analyzed the data with the larger cohort, and it showed actually no significant difference. So actually, balloon, especially the low dose, the paclitaxel DCB has actually O18 wire compatible feature. These days I use either O18 or sometimes O14 wire if I apply protection device. So for that reason, actually the Ranger is more convenient to use. But there are more data, evidence for impact DCBs. So for patients with severe lesions and recurrence of the after revascularization, then I prefer to use impact DCB.
I see.
It's also the our finding is Taiwan because from the basic study, they say the impact DCB have more distal embolization of the drug, but in Taiwan, surveillance rate, even no hospital find there is a slow flow or distal slow flow or no flow phenomenon after impact DCB. However, on the contrary, the animal study show that the Lutonics have the lowest distal embolization. However, clinical is different, quite different. In fact, it's a highest prevalence of no flow, number one in Taiwan. So that's our finding in Taiwan.
Does anybody see that slow flow in claudicants with good outflow? Or is it only in CLTI patients? What do you guys think? Because I've always generally seen slow flow in the patients who have kind of restricted outflows, single outflows or just the CLTI patients. I think Impact Deep really did kind of prove that point, and so it is a challenge, I think.
Dr. Ko, just from a technique perspective, so you have a sheath in the left CFA?
Yes.
Okay.
This is Viking sheath. Yeah.
Okay. And is the sheath hubbed? Because I see you reach over and put your, hands underneath the II, and I'm very particular about that. In such a situation, what I would do is use a long sheath and extend the sheath in the hub, put it on, let's say, the lateral aspect of the SFA. Use tegaderms to kind of fasten it down, so you're not reaching over. Basically, you're just working almost like using a sheath in the right groin to treat a left SFA.
I see.
But I mean, our facility has lead-coated gloves, but still, reaching over, I just kind of, very particular for me.
I think, Michael, that's such a great point. The challenge is that I don't think that the device companies have heard you, because they still have this very odd length of catheter. So when you extend to 90 centimeters, now you've taken away basically 45 centimeters of your geography that you can get to. That to me is a wonderful idea if they would actually extend and make them longer. Now they've got 200 shafted balloons, sometimes even 300, but it does become a bigger challenge if you don't have that in your lab.
So another point for this kind of a CTO SFA issue, I want to ask Professor Gao that your strategy is always integrate attack first, and if failure, go to retrograde bidirectional, right? So we will consider re-entrant device to save time, and because I really do distal puncture, because my strategy is integrate failure, then go to re-entry, because it saves a lot of time.
But these days I rarely use re-entry device. So if you have more experience with distal puncture, then actually the success rate is very high. So maybe I use one re-entry device 1 or 2 years, maybe. It's not common.
And 1 or 2 weeks.
Yeah, at least distal and mid portion of SFA is okay. Go back. And the proximal part is does show some still remain dissection. I think I haven't treated the proximal segment with DCB yet, so I think I will use another balloon for the proximal segment. So do you have any suggestion? I think our time is almost up. So do you have any suggestions or comments about this case?
I think this is a great case. I think the origin needs a little bit of help, and I think that may give you a little bit better flow, and I'd be interested if we had more time to look at your filter when it comes out. But I think just balloon seems to be the right choice here. Does anybody want to stent anything?
7 80짜리 하나 줄까요?
Maybe go a little bit REO 30, open up that SFA and deep profunda. You can see the ostium better to see if it's really an issue.
Okay. So I think I will treat this lesion with a 7 millimeter balloon.
What's your concentration of contrast and saline when you do your DSA?
1 to 9. So 1 contrast and 9 saline.
Wow, that's good.
And so is there IVAS image after the balloon dilatation after DCB?
Yes, I will do it. Yeah.
There you can see the dissection. I think it's a great example of obliquity. Really does show things in a nice way.
Ko
이거
sensei,
좀 띄워주세요.
Dr. Ko, the very good technique. Thank you very much for the good wiring and then the atherectomy and the DCB. Very reasonable approach. But the time will be a little bit over. So the today's live demonstration session closing now. Thank you very much, Dr. Ko.
Okay, thank you very much. Bye-bye. See you.